will be moderated by Professor Dr. Rajan Pandey. I request Professor Pandey to kindly take over the session and to proceed.
Thank
Professor
you, sir.
Pandey, please.
Thank you, sir. Am I audible?
Yes, yes.
Yes, yes.
Yes, sir. Yes.
So it's my privilege that I would be moderating a session of a person who is was a senior fellow to me in the Institute IPGMAR. Professor Mukherjee was doing his residency when I was still preparing for my MD. And sir was working with a unit which was also in charge of developing nephrology in our institute. So this is probably a thing which may not be known to the most of the participants, but sir was already exposed to nephrology when nephrology was being developed. So, and to introduce him as an orator is eloquent, his content is very focused, and I think by the end of the session, the participant would benefit immensely from two aspects. One, those who are students, they would be knowing how to approach the answer in the question paper, which can also fragment for short questions. And whatever he would narrate, I am hopeful definitely that will also be of use in practice. So I'll request Professor Mukherjee to take over from here. Please.
So, good morning, everybody. First of all, I must express my sincere thanks to the scientific committee of our API West Bengal branch for giving me an opportunity to face our students, because I have retired a year back, along with none other than our professor and head of Department of Nephrology, Professor Rajan Pandey, and Professor M.K. Roy, who is the course coordinator of the master class, along with the able support of Professor Jyotirmoy Paul, Professor Uday Ghosh, Professor Soumitra Ghosh, Professor Sudhir Ghosh. It's running like very attractive program to all our students spread all over the state. In few words, I start my deliberation. I shall be able to present before you the approach to chronic kidney disease, as the topic is. But it is important to realize that chronic kidney disease is associated with so many important etiological disorders and comorbid conditions with which the patient present before the clinician. It becomes an ample task for the clinician or the caregiver to find out not only the etiology of chronic kidney disease, but also the stage of chronic kidney disease, the associated abnormalities, not only in reduction of excretory function of the kidneys, resulting in accumulation of different toxins, not only in simplified, but the that takes place with the progressive deterioration of renal function, as well as the chronic kidney disease is associated with a huge element of systemic inflammation, which is now an important issue to be unraveled by the researchers all over the globe, because even with the advent of very successful renal transplant procedures, which is not affordable by a large number of population, it is important to provide renal replacement therapy in the form of hemodialysis at the appropriate point of time, and more importantly for an internist to refer the patient to a nephrologist at the appropriate point of time so that he can serve the patient better. In my experience, I have seen the nephrologists are usually called upon when the patient has progressed with the illness, sometimes with irreversible stage, and the management becomes cumbersome at some point of time. If I show you the next slide, I shall be putting forward the learning objectives of this class. So far as the approach as the heading of the title of the talk, we have to take the history as we all do in each and every medical patients. Examination thoroughly goes a long way, sometimes identifying some positive factors, sometimes some precipitating factors, sometimes some aggravating factors of the baseline renal function. And also, it is important to unravel some systemic diseases which has afflicted the kidney function quite appreciably. Investigations are also very important in this particular setting of illness because many of the illnesses in medicine may be diagnosed by history and examination, and investigations only supplant to a small extent. But in chronic kidney disease, some investigations are tremendously helpful to identify certain derangements, not only related to fluid electrolyte and acid-phase homeostasis, but to find out the hormonal dysregulation as well as the metabolic changes that takes place, and also the associated inflammation, which I talked about earlier, is one of the very important areas where the researchers are trying to unravel so many important issues associated with the presentation of chronic kidney disease. Biopsy is golden. Histopathology of the diseased organ can give rise to the diagnosis. But in this case, chronic kidney disease, sometimes the kidneys are so small that biopsy may not be possible or extremely risky. Definition of chronic kidney disease needs to be reiterated. We have to know that identification of risk factors and thereby periodic checking of the renal function goes a long way because the population-based screening of renal functional deterioration, either in the form of GFR or the albuminuria or the urea creatinine estimation, is not found to be fruitful. Etiology is extremely important, if possible, and clinical and laboratory manifestations of chronic kidney disease, which
Professor Mukherjee, some sound is coming. Please check your sound system.
mainly the sodium, potassium, and water. The acid-base disorder, particularly the acidosis, metabolic acidosis that's kicking, calcium and phosphate metabolism, and associated hormonal surge in the form of secondary parathyroidism, as well as rise of growth factor 23, as well as the diminution of the active component of 125-dihydroxyvitamin D3 is extremely important. But more and more important is the cardiovascular illnesses that come along with any stage of tell about the stages where diabetes and hypertension may be the contributor in the formation as well as in progression of chronic kidney disease, but also due to any cause, chronic kidney disease stage 1 to stage 5 are associated with increased cardiovascular morbidity and mortality, and it is extremely important to address effectively, particularly in the earlier stages of chronic kidney disease. So they are diagnosed mainly by the laboratory investigation of urea creatinine or estimated GFR. Urinary symptoms in the form of increased frequency, polyuria, oliguria, normal color, hematuria, floppy urine, pyuria, dysuria, urgency, emergency, chronic nocturia, incontinence, come up with different subsets of urinary disorders which can affect the renal function over time. Flank pain and heaviness can also be found in papillary necrosis, as well as heaviness found in autosomal dominant polycystic disease of the kidney. Uremic symptoms, particularly anorexia and the associated malnutrition, nausea, vomiting, these are the uremic symptoms. Fatigue is also very common in them, particularly when associated with anemia.
Dr. Mukherjee, slides are not running.
Slides are not running.
স্লাইডটা সরছে না, স্লাইডটা আপনি
Slides are not running. It's
ফুল
static.
ভিউ করুন, ফুল ভিউ। আগে স্লাইড ভিউ করুন, তারপর ক্লিক করুন।
আর ফ্যানটা বন্ধ করতে বলো। সাউন্ড আসছে, ফ্যানটা বন্ধ করো।
হ্যাঁ, খুব সুন্দর আসছে।
পাখাটা বন্ধ করো।
না না, আওয়াজ আছে, ঠিক আছে। পাখা বন্ধ করলে থাকবে কি করে?
So far as the approach is concerned, I was discussing that the pharyngitis, if associated with chronic post-streptococcal glomerulonephritis, sometimes some acute systemic disease with fever, joint pain in the form of polyarthritis, rash, and oral ulceration points towards the diagnosis of systemic lupus. The fluid status is important for any clinician, particularly when there is low limb swelling with history of orthopnea, weight gain. So we think about volume overload, and the volume depletion can be sometimes interactive, and this can be presented with the symptoms of thirst, weight loss, oliguria, lightheadedness. So it is important to ascertain all the symptoms when it is present. But let me remind once again that stage 1 and stage 2 CKD are usually asymptomatic, and when the people who are harboring the risk factors are periodically tested for estimated GFR or urea creatinine, we land up with a diagnosis. And sometimes it gives rise to some skepticism or denial on the part of the patient or their family members about the onset of renal disease. But we have to counsel them effectively so that that doesn't become in disarray. At the same time, we have to try to unravel some acute or subacute cause, which is remediable by appropriate treatment within no time. So in the past history of acute or recurrent renal illness goes a long way to identify that this is probably related to the acute insult that have been afflicted by the individual some years back. And recurrent episodes of acute renal injury can also give rise to chronic kidney disease on later date. So past history of acute or recurrent renal illness is of importance. Family history, particularly when there is pain in the loin and there is presence of the diagnosis of autosomal dominant polycystic kidney disease in some of the family members, it is important. And there are certain integumentary, visual or auditory findings associated with Alport's fatties and cystinosis, and they are extremely uncommon. Dialysis and transplant history is also important. Medications are tremendously important in the modern era, particularly when the people are using rampantly the proton pump inhibitors and non-steroidal anti-inflammatory agents. It is important to unveil the medication history so that that can be effectively contributing in the genesis and perpetuation of chronic kidney disease. Personal and social history is important. Some cocaine abuse have been found to be associated with development of chronic kidney disease. Some environmental factors, particularly we know the aristolic acid associated with the Chinese herbs, as well as the Balkan nephropathy is rampant in certain parts of the geographical area. Menstrual history is important because that sometimes gives a clue about the hormonal dysfunction associated with chronic kidney disease. But most importantly, and most relevantly in our day-to-day practice by an internist, history of diabetes and hypertension is of paramount importance, and it should always be found out and reiterated. But let me put forward before all of you that the diagnosis of diabetes may not be known to the patient and their family members. Some people are so reluctant to check their blood sugar, they are unknown about its existence, and sometimes may land with some stage of chronic kidney disease associated with the first diagnosis of diabetes. And we also need to know that type 1 diabetes and type 2 diabetes both gives rise to the development of diabetic nephropathy and then progression to chronic kidney disease. But because of the huge prevalence of type 2 diabetes in comparison to type 1, type 2 diabetes contributes to the huge burden of chronic kidney disease everywhere in the world, but mainly in the North American and European population. In our population also, type 2 diabetes happens to be the #1 contributor of chronic kidney disease. So for examination, GL survey, build nutrition, faces, anemia, edema, neck veins, pulse, blood pressure, respiration, temperatures, and skin condition thoroughly to be checked. It is important that sometimes the GL survey finding can give you an extraordinary clue to the identification of the etiological cause.
অপূর্বদা সাউন্ডটা একটু ডিস্টার্ব করছে। হ্যালো অপূর্বদা, সাউন্ডটা ডিস্টার্ব করছে, একটু ইকো হচ্ছে, আর কিছুভাবে ঠিক করা যায় কিনা একটু দেখুন। সাউন্ডটা একটু ডিস্টার্ব করছে আর ইকো হচ্ছে।
Abdomen lump
ইকো
and
হচ্ছিল খুব।
renal angle tenderness, renal bruit and palpable bladder, which often signifies obstructive uropathy. In the precordium, it is important to identify the left ventricular hypertrophy because hypertension is a common association of chronic kidney disease, sometimes apical gallop, S4 suggesting atherosclerosis, and pericardial friction rub in uremia, though not common in the modern day of renal replacement therapy setting all over the state. But when the patient is negligent and do not undergo the proper treatment or is not adherent to the proper prescription and the dialysis has not been offered in the proper time, it is possible that pericardial friction rub can also be available. Chest, dullness and breath sounds in the form of pleural effusion. Let me tell you, the congestive heart failure may be the presentation of a patient with chronic kidney disease, and that can be associated with the right-sided minimal or moderate pleural effusion. Sometimes nephrotic syndrome, proteinuria, may be associated with chronic kidney disease, and the element of the nephrotic syndrome may give rise to transudative bilateral pleural effusion. Fundoscopy goes a long way in identifying not only the hypertensive changes which might be harbored by the chronic kidney sufferer for some length of time, but in diabetics also, diabetic retinopathy, it goes more closely to diabetic nephropathy, and thus identification of diabetic retinopathy is important. And when available, the combination of the same can forestall the requirement of even biopsy procedures. Asterexis, though uncommon in the present era, but when present need to be identified. In fact, the CKD is frequently clinically silent in the early stages, so screening of patients without signs and symptoms at routine health visits is important. I want to reiterate this fact that the people who are at risk of developing chronic kidney disease should not be deprived of frequent checking of their renal function, because identifying them in the stage 1 and stage 2 disease goes a long way in preventing progression to chronic kidney disease in majority of the individuals, though not uniformly true, but in majority it can be forestalled. At the same time, aggressive management of the coexistent risk factors, particularly emphasizing the cardiovascular risk factors prevailing in the individual, can address the cardiovascular complications, which is the commonest cause of death and morbidity in people suffering from chronic kidney disease at any stage. So in approach, we have to do serial urea and creatinine. Let me tell you that serial urea and creatinine is important to identify the early stages. And it is also important that when a person comes with a kidney disease in the form of raised urea and creatinine, and if some values or reports are available done within a few months or year, we can tell that this could be subacute or acute in nature rather than thinking of chronic kidney disease. When it is unavailable also, it is important to see the manner and fashion the patient presents. And the other systemic features may point towards something acute illness which has given rise to renal dysfunction. As for example, if you get a SLE patient and the SLE is presenting with a fever, anemia, lymphopenia, the polyarthritis, the skin rash, and the oral ulcers, it goes a long way in identifying SLE. So renal dysfunction can be attributed to that systemic illness only. So mere USG of the KOP region can give you a lot of information. And USG gives you an information about the presence of both kidneys, no congenital abnormality, whether they are symmetric in nature, whether there is any difference in the size, and whether it is associated with the renal mass or any obstructive uropathy is present or not. It is also important to identify that more than 1 centimeter difference of the renal size points to unilateral renal disease or unilateral pathology, or sometimes renovascular disease, which has got special affection to that particular site, even being bilateral. So subjecting the patient to color Doppler examination or other imaging procedure, we can unveil the renovascular disorders and can treat them effectively if identified early. It's also very important to note that reflux neuropathy, nephropathy, can be identified by voiding cystogram. But it is to be reminded to all of you that when a patient comes with the stage of CKD and you get the history of childhood recurrent urinary tract infection pointing towards reflux, and if there is USG identified asymmetry of the kidneys with renal scars in the poles of the kidney, we suspect that this could be originated from reflux nephropathy. But this reflux nephropathy giving rise to CKD is, even if the CKD stage has been identified and the cause is reflux, then subjecting to voiding cystogram may not be rewarding because of the fact that by the time the patient enters into the stage of chronic kidney disease, the reflux may have resolved, or even if present, addressing the same will not be able to improve the chronic kidney disease status. It is also very important to make the precaution that contrast-induced nephropathy is one of the important elements of increment of renal functional decline, and thus it should better be avoided when possible. Now, biopsy, as I told, that this is a very golden for many diagnoses, as you all know, but in the setting of chronic kidney disease, it is not always indicated, even in the early stages. And when the kidney size is not that small, as for example, in diabetic nephropathy in early stages, or HIV-associated nephropathy, or amyloidosis, and sometimes in polycystic or autosomal dominant polycystic disease of the kidney size may not be that small. But also then, you don't have the indication of biopsy because you get the diagnosis by proper history, proper examination, proper imaging techniques, and all that, so that you can avoid the biopsy procedure, which is particularly contraindicated when there is bilateral small kidneys because of the increased chances of bleeding, increased chances of injury to the vital organ. The patient might have bleeding diathesis along with, The patient might be on anticoagulant because of certain other cause. So it is important that the small kidneys, usually bilateral small kidneys, take a long time to develop, and it is almost diagnostic of chronic kidney disease. And when there is bilateral small kidney, whatever might be the etiology, it is associated with a lot of fibrosis, a lot of destruction of the original architecture of the kidneys to allow you to arrive at a specific diagnosis. And the window of opportunity for offering the appropriate treatment may be lost, particularly when the patient presents with chronic kidney disease with bilateral small kidneys. It is also important to remind all of you that sometimes this percutaneous biopsy procedure, which is USG guided, done and may have some other contraindications in the form of uncontrolled hypertension, active urinary tract infection, or the patient might be harboring severe obesity, or there might be bleeding diathesis, which where biopsy attempt need to be avoided. But when it is possible, particularly when the patient is suffering from some other disease, but you, the caregiver, is thinking that something has superimposed on the background chronic kidney disease and needs to be identified and treated to achieve return of the patient to baseline renal function. It is possible that the exposure to nephrotoxin or development of some interstitial nephritis is the offending factor, and it can be identified promptly if you envisage upon the biopsy procedure. But it is also very important to take history properly and to identify the offending factor which has crept in a patient already suffering from chronic kidney disease, maybe stage 1 to stage 3, but in stage 4 and 5, because of the bilateral small kidneys, in majority of the situation, biopsy needs to be avoided. A case may be presented to before you, a 41-year-old male with long-standing history of hypertension and diabetes, complaining of pruritus, lethargy, lower extremity edema, nausea, and emesis. He denies any other medical illness. Examination reveals well-developed, well-nourished male in moderate distress. There is bilateral lower limb edema, blood pressure 180 or 110, pulse is 80, respiration rate 24, he is afebrile, body weight is 76.5 kg, and fundoscopy shows heavy leaking and copper wire changes. Cardiovascular system S4 gallop is present, and skin has superficial excoriation suggesting of scratch. So these are the history and examination finding pointing towards the development of chronic kidney disease along with volume overload, and there is hypertension associated and mainly contributed by the extracellular volume expansion. So these are the investigations which are commonly found, and I have put forward these sort of reports so that you can think about the presence of not only anemia, but there is a reasonable blood sugar value. As we all know, that progression of chronic kidney disease gives rise to amelioration of hyperglycemia to some extent and reduction of anti-hyperglycemic therapy, which have been quite effective and now need to be avoided. There are huge rise of burn as well as creatinine. The calcium is low, the phosphorus is high, the albumin is low, the sodium is normal or slightly low, the potassium is raised, the iron is low normal, ferritin is raised, and the transferrin saturation is 25, and the parathyroid hormone is 895 picogram per milliliter. If you look at the urinalysis, there is protein plus, and the size of the kidney 8.3 on the right side and 8.1 centimeter on the left side, and there is increased cortical echogenicity. So altogether, this is a picture of chronic kidney disease, and he has got sufficient waxy cast in the urinalysis as well, pointing towards nephrotic syndrome. As well, though the protein is less, I do not feel this is nephrotic syndrome, but hypertension. So all taken together, this could be a case of diabetic nephropathy, which is sufficiently advanced and for a prolonged period of time because of the duration and the degree of hyperglycemia has contributed for the same, and hypertension, which is more likely to of chronic kidney disease, is contributing heavily on the patient's presentation at the brain point. The CKD is defined either kidney damage or a decreased glomerular filtration rate of less than 60 milliliter per minute per 1.73 square meter for at least 3 months. It is important that this is the definition of CKD enunciated by the Kidney Disease Improving Global Outcomes as well as the Kidney Disease Outcome Quality Initiative. But we know that albuminuria is also tremendously important in majority of situations, and the combination of low GFR and the degree of albuminuria usually determines the patient's progression to further escalation of the chronic kidney disease. Here is the list of risk factors. As I was discussing, that stage 1 and stage 2 are often asymptomatic, and they are presenting before you without any symptoms suggestive of chronic kidney disease. But it is important that the population-based screening, though not advisable, but the people who do have this sort of risk factors, they need to have periodic check of their renal functional status to identify chronic kidney disease as early as possible. It is important to realize that GFR, which becomes 120 milliliter per minute per 1.73 square meter of body surface at the age of 20-25 years, becomes lessened over the progression of age, and only age can give rise to 1 milliliter of diminution of eGFR every year, so that a male person with the age of 70 can have a GFR of 70, but this has got a huge variability amongst the population according to the geography, according to the biological age as well. So it is important, but we have to take it into serious concern because that signifies compromise of the renal function. And if this patient is being assaulted with some nephrotoxin exposure or some progressing towards more deleterious renal function is important. It is also important for all of us to appreciate that medication dosage may need adjustment because of the GFR 70 at the age of 70, which may appear to be physiological, but need to be taken seriously because this definitely signifies diminution of renal function. Previous acute kidney injury is also very important. And if we get the presence of proteinuria, abnormal urinary sediment, structural abnormality of the urinary tract, so all these are important. But let me state before you that childhood obesity is also now being identified to be a very important risk factor, particularly when the population do have an increased burden of chronic kidney disease, as well as there is increased burden of physical inactivity and unacceptable weight gain with increased waist circumference in the childhood. They do have increased propensity to develop not only type 2 diabetes, not only systemic hypertension, but also chronic kidney disease separately. Obesity has been identified to be an independent risk factor of development of chronic kidney disease. But let me reiterate before all of you that hypertension and diabetes together happens to be the commonest cause of chronic kidney disease, of which diabetic nephropathy is significantly important. It is the change of glomerular architecture that happens with chronic kidney disease needs to be understood by each and every participant in this particular class. What I want to emphasize that the normal glomerulus, which is being shown on the left side, is being changed to a different sort of appearance in a hyperfiltrating glomerulus. But this is because of the maladaptation that takes place, whatever might be the initial insult. The initial insult, whatever might be either in the form of inherited disorder or immune complex deposition as we get in glomerulonephritis, or if there is some tubulointerstitial injury, all these gives rise to some changes in the nephron mass so that the nephrons are dying, and the dying nephrons are not contributing to the physiological function of the kidneys, and the remaining viable nephrons are now become hyperactive, and in the form of hypertrophy and hyperfiltration, they try to compensate the renal loss, renal mass loss, and thereby they do have hypertrophy and hyperfiltration to maintain the GFR. Over a period of time, this adaptation to maintain eGFR becomes maladaptive only because the increased flow and increased pressure in the glomerulus gives rise to destruction of the glomerular architecture, the loss of podocyte function, and there is filtration barrier alteration, and there is increased adhesions of the tissues and production of sclerosis. There is enlarged arteriolar segments, and all these is a feature of hyperfiltrating glomerulus. And this adaptive hypertrophy and hyperfiltration becomes maladaptive over a period of time, and thus this is the most important pathophysiological cause of the renal structural deterioration, whatever may be the initial assault. Now, this is the prognosis of CKD by eGFR and albuminuria categories. Here, in this particular cartoon, you can identify that the patients might have a normal or high GFR, but this is a situation where there is normal or mildly increased albuminuria, and thus the patient has got a grade 1 CKD. In grade 2, there is mild decrement of the eGFR, 60 to 89. If the albuminuria is less, then it is A1. If moderately increased albuminuria, that is 30 to 300 milligram per day, or 30 to 300, or more than 300 milligram, it is severely increased albuminuria. Now the point is, when you have got G1 with A1, this is green. If there is G2 with A1, that is albuminuria is normal or mildly increased, it is still green. But when the albuminuria increases, it is transforms to the gray color, and when it is more, even the eGFR being 60 to 89, the presence of severely increased albuminuria is a pointer towards the renal functional deterioration and glomerular functional diminution, pointing to chronic kidney disease progression. And this could be one of the areas where you might have to identify the proteinuria cause. And this is quite common in diabetic nephropathy. And this time you can refer the patient to a nephrologist for his opinion. But all these red bars are signifying that the areas where nephrologist consultation is mandatory or imperative. But I was talking about the diminution of eGFR with progression of age. If you find that the renal function is compromised and the eGFR is proportionate to the advanced age in an elderly individual of 75 years, but periodic checking of the urea creatinine and eGFR is not showing any progression, and particularly in the absence of albuminuria and controlled blood pressure, you may not refer to a nephrologist. But identification of albuminuria along with this sort of situation in an elderly individual where the eGFR is less than 70 or less than 60, and there is appearance of albuminuria or the hypertension is not controlled effectively by a suitable combination of 3 drugs or more, you need to refer to nephrologist for fine-tuning of the situation. This is the staging that I was discussing. Stage 1, normal GFR with proteinuria. Let me remind you that the normal urinary protein excretion is 17 milligram per gram of creatinine per 1.73 square meter body surface area. And in women, it is less than 25. And that's the normal urinary excretion of albumin. So this has to be remembered, and any minute elevation of the spot urinary creatinine albumin ratio, done over a period of time must be 2-3 values are to be taken within 3 to 6 months of time. And you identify that there is mild rise of proteinuria with mild diminution of estimated GFR. It is important to address the issue effectively so that the renal functional deterioration can be halted. These are the different stages. I have pointed out that the low risk of progression of kidney failure in the 3A, B stage, but there is high risk of progression of kidney failure to kidney failure. With all these stages, the cardiovascular complications are of tremendous importance. But when your patient is in stage 5, and the stage 5 may be dialyzed, maybe on maintenance hemodialysis, maybe transplanted, you need to have some skepticism about aggressive management of cardiovascular disease, because more than 50% of them do have some cardiovascular complications along with. And in the stages early, 1, 2, 3A and 3B, it is very, very important for the caregiver to address the cardiovascular risk factors to reduce the cardiovascular disease burden, which is very much increased in all stages of chronic kidney disease. And you must remember that albuminuria and the diminution of GFR, both are separately identified and established to be a risk factor of cardiovascular disease. Mild diminution of GFR and albuminuria both are associated with increased cardiovascular morbidity and mortality. Microalbuminuria is also identified to be associated with a systemic microvascular involvement as well as widespread endothelial dysfunction. These etiologies of diabetic kidney disease, glomerulonephritis, hypertension-associated CKD, autosomal dominant polycystic kidney disease, and other cystic and tubulointerstitial nephropathy are contributing to the genesis of chronic kidney disease to the tune of 90% or more in involvement of the kidneys all over the world. Though diabetic kidney disease may be contributing to 40%, 45%, 50%, even 35% in some geographical areas, and glomerulonephritis may come second. But hypertension associated with CKD is important because sometimes when you do not get any other cause, particularly in the form of glomerulonephritis, diabetic kidney disease, we tend to call them hypertensive nephrosclerosis. But it is important to realize that sometimes some subclinical primary glomerulonephritis in the form of focal segmental glomerulosclerosis or global segmental glomerulosclerosis may appear in the scenario subclinical, and this can be the cause of hypertension, and sometimes you wrongly ascribe as the cause. So they have to be thought about separately because this has been found to be an important offender. And another subset of population is really suffering, have hypertension associated chronic kidney disease, and their hypertension is not only limited to the kidneys, but this hypertension associated vascular disorder has already involved the cardiac as well as cerebrovascular tree in the form of cardiac disease, cerebrovascular disease. And you must be agreeing with me that the more improvement of the cardiac emergencies as well as the cerebrovascular emergencies with the newer form of treatments has allowed the elderly individual to live for a longer period of time to land in a situation where there is ischemic changes with the renal arteries, giving rise to ischemic involvement of the kidneys and progressive hypertensive nephrosclerosis. But these need to be associated with the widespread vascular involvement, as I have mentioned. Pathophysiology is important, and we need to realize that kidneys are not limited to the diminution of excretory function only. The excretory function is definitely diminished, and thus we get raised urea and creatinine. But as I told, that the accumulation of so many toxins which are not being excreted by the kidneys are not limited to urea and creatinine. We know there are lots of other substances which are nitrogenous metabolic products, which may be hydrophobic, water soluble, which may be charged, which may be uncharged, and they get accumulated and give rise to so many bizarre involvement of the various organ systems of our body. But this is only related to the failure of excretory function of the kidney. But while the excretory function is causing accumulation of toxins, there are also changes related to sodium, potassium, water, as well as acid-base homeostasis. And it is also important that the calcium, phosphorus metabolism and its associated abnormalities in the form of raised parathyroid hormone, raised fibroblast growth factor 23, and diminished action of the active 125 dihydroxyvitamin D3, they all contribute to the different manifestations of this illness. We need to realize that several other hormones may be disorganized because of diminished excretion, because of altered degradation, because of altered regulation in the phase of chronic kidney disease. And the most exciting thing that is, again, I am telling because it is a repetition, but that's the way, that's the area of research in the present field, that chronic kidney disease is associated with a gross systemic inflammation. And this inflammation is associated not only with the raised CRP values, raised CRP being an acute phase reactant, it is also associated with the diminution of negative acute phase reactants in the form of albumin or fettrin. Fettrin happens to be one of the important molecules which is associated with the insulin sensitivity and the proper distribution of the body fat, as well as incidences of atherosclerotic vascular disease. This inflammation is related to catabolism, and the protein, carbohydrate, fat metabolism is altered, and there is atherosclerosis calcification syndrome, and this is one of the areas where the treatment needs to be very aggressive, and most likely they need to be prevented rather than when it appears the treatment is not that salutary. So although CKD is clinically silent, we have to keep in mind the fluid electrolyte status, the cardiovascular status, the bone response, and the disturbances of the minerals associated with the bone turnover, as I just mentioned. Nutritional status. Anemia is tremendously important because anemia, particularly in stage 3 onwards, which is always present, is associated with the decreased quality of life, as well as increased incidences of fatigability, the distress associated with the daily work life, and there is also increased incidences of heart failure, left ventricular hypertrophy. We need to know that this is associated with the diminution of cognitive function, memory loss, and the chronic anemic patients associated with chronic kidney disease might have an increased mortality, because if it is not addressed effectively from the beginning, that is a contributor to not only progression of the kidney disease, but more and more events associated with a heart failure and sudden death, which are the most important contributor of cardiovascular system related death in chronic kidney disease sufferer. Nervous system also deserves special mention. Sodium and water, as I was talking about, in normal physiology, dietary intake and urinary excretion of sodium matches, and same is of water. But dietary intake, when exceeds urinary excretion, that happens with chronic kidney disease. There is extracellular fluid volume expansion, and this gives rise to development of hypertension. And this extracellular fluid volume expansion and related hypertension is sufficient enough to give rise to augmentation of renal injury, and high dose of loop diuretic may be needed to tackle this situation. Most of the cases are, there is isotonic extracellular fluid volume load, so water restriction is often not needed. But when there is hyponatremia, which is a rarity in chronic kidney disease, we need to only provide water restriction to address the issue of hyponatremia. There could be some other patients with impaired renal conservation, and these people might be prone to the development of hypovolemia and shrinkage of the extracellular volume because of some other added factor like sudden GI loss due to vomiting or diarrhea. And there you have to be very prompt to just reduce the diuretic dose, and we have to take care of the attainment of euvolemia so that the renal perfusion, which is going to be under-perfused, and thereby there could be a prerenal element into it, can be avoided. And sometimes judicious use of normal saline can be given, but that's risky and that has to be closely monitored because the patient's return to the baseline renal function is extremely important. Potassium rise is not parallel with the lowering of GFR. As you all know, that the potassium is aldosterone dependent secretion in the distal nephron, as well as there is augmented potassium excretion in the GI tract in patients with chronic kidney disease. And we need to understand that there are precipitating factors of hyperkalemia in majority of situations: increased dietary intake, hemolysis, hemorrhage, transfusion of stored blood cell, and metabolic acidosis all gives rise to hyperkalemia. So we need to identify which is the cause of hyperkalemia. I want to emphasize the use of different drugs which can add to the risk of hyperkalemia, particularly in the form of ACE inhibitors and ARBs, and also the mineralocorticoid receptor antagonists in the form of spironolactone, or other agents in the form of epinol, amiloride, and they need to be avoided or reduced in their dosage. So that I personally feel they need to be avoided in the setting of hyperkalemia totally. And the dose of ACE inhibitors and ARBs, as have some salutary long-term benefit, need to be adjusted to such an extent that the hyperkalemia can be avoided to a great extent. But it is also important to realize that in diabetes, the hyperkalemia occurs very early, and because hyporeninemic hypoaldosteronism occurs in them, and the distal nephron being predominantly affected in obstructive neuropathy and sickle cell nephropathy, they do get hyperkalemia more often as compared to others. Metabolic acidosis, we have to remember that this ammonia generation may be low, and thus the protons are retained, and there could be hyperkalemia associated with metabolic acidosis, and this hyperkalemia definitely depresses the ammonia production, and thereby hyperkalemia with hyperchloremic metabolic acidosis, which is usually non-anion gap metabolic acidosis, are encountered in stage 1 and stage 3. But it is important that as the disease progresses in stage 4-5, anion gap metabolic acidosis ensues, and the patient might be harboring a combination of both with the stage 4 stage of CKD. But it is to be remembered that the pH rarely goes less than 7.32, but it is important that the bicarbonate level has to be estimated. And if it is less than 20 to 23 millimole per liter bicarbonate, then it is important that you have to provide some sodium bicarbonate solution in the form of alkali so that the patient's acidosis can be addressed effectively. Because early addressing acidosis is not only effective in reducing the catabolic state associated with the protein energy malnutrition, and this acidosis increases the same, and it is also contributing to progression of renal disease. It has got important contribution to the metabolic bone disease as well. So bone disorder in CKD, we need to understand that when the GFR becomes lower, the phosphate accumulation takes place. And this phosphate accumulation gives rise to stimulation of fibroblast growth factor 23 from the osteocytes and increased parathyroid hormone from the parathyroid gland. And when this stimulation is more and more, there is increment of the parathyroid gland mass. There is associated calcium diminution, and this is also being due to the FGF23 related gastrointestinal calcium absorption diminution, and they gives rise to the changes of the bone functions. And this bone turnover may have different manifestations. There could be osteomalacia only spread due to a diminution of active form of the vitamin D, but it could be renal bone turnover becoming excess, giving rise to high turnover bone disease, and there could be diminished turnover bone disease or adenemic bone disease. Altogether, they are called renal osteodystrophy. And what is important for all of us to realize that many patients do have a combination of all or different problems of this bone turnover may be associated at a single point of time. So high turnover bone disease is caused by the increased parathyroid hormone, and it is important that the fibroblast growth factor 23 suppresses calcitriol production after being released heavily from the osteocytes. And high fibroblast growth factor 23 is independent risk factor for mortality. And it has been found that the fibroblast growth factor 23 is increased earlier, even in the absence of hyperphosphatemia or increased parathyroid hormone. And if it is allowed to progress to a high rate that is associated with more and more incidences of left ventricular hypertrophy and cardiovascular mortality. We need to understand that the osteitis fibrosa cystica is a condition of high turnover bone disease where there is cyst formation, fibrous tissue formation at different parts of the bone structure. And when there is excessive fibrosis inside the bone and cyst formation, there could be associated some hemorrhagic element, and this gives rise to some looking like a brown tumor, and the cyst might be elevated, and when looking brown, they call the osteitis fibrosa cystica with brown tumor. It gives rise to not only derangement of the osteoid tissue, but also excessive fibrosis of the bone and bone marrow. And this is one of the important contributor of erythropoietin resistance, as you can well surmise that effective bone marrow, if diminished by coexistent fibrosis, the erythropoietin are unlikely to work effectively. Adenemic bone disease, increased prevalence in diabetics and elderly. That's very important point to remember, that more diabetics and elderly individuals do have more incidences of adenemic bone disease. But as I pointed out, the combination of all osteomalacia, high bone turnover disease, and adenemic bone disease can coexist. Due to excessive suppression of parathyroid hormone and chronic inflammation, the chronic inflammation happens to be one of the important contributors, not only in genesis of malnutrition as well as deprivation of the health, but they also contribute heavily to cardiovascular mortality and vascular calcification associated with increased parathyroid hormone. They give rise to increased fracture and bone pain and cardiovascular calcification. Adenemic bone disease is associated with the low or normal PTH, and this calcium, when enter into the body, either in the form of calcium binding agents for the phosphate lowering, or the patient have been given the calcium containing dialysate solution, there could be some excessive calcium level which is associated with depression of the PTH, which become normal or even low. And there is soft tissue calcification to a great extent, giving rise to this sort of swelling at different parts of the body, which is called tumoral calcinosis. Calciphylaxis was initially considered to be an element which is only associated with secondary severe hyperparathyroidism. But with passage of time, we have seen that this could be contributed by some other things, and it is not necessary that secondary severe hyperparathyroidism needs to be present. It may present with the libido reticularis either in the leg or thigh or the abdomen or the breast, and these areas may be libido reticularis. Then there is an occlusion of the artery, and there is some necrosis of the surrounding tissue, and there is deposition of calcium in the different parts of this affliction. This is a very, very dangerous thing, and sometimes it has been attributed to warfarin usage, and warfarin usage needs to be stopped once there is calciphylaxis, because warfarin has got some link about the matrix GLA protein reduction, which is important in prevention of vascular calcification. Now, cardiovascular disease, I again and again reiterate that anemia, hyperphosphatemia, hyperparathyroidism, increased fibroblast growth factor 23, sleep apnea, generalized inflammation, exogenous erythropoietin are all significantly important in increasing the cardiovascular disease risk as the CKD-related risk factors. It is also important that the CKD-unrelated risk factors, maybe in the form of diabetes, hypertension, hypervolemia, and increased sympathetic activity, as well as hyperhomocystinemia, are contributing to the cardiovascular ill health. But the CKD-related risk factors are really important, which are not present in patients who are devoid of kidney disease. So we need to understand that the patients, while being allowed to progress with so many different derangements of the metabolism, excretory function, as well as altered regulation and the altered metabolism and nutrition, they need to have aggressive management of cardiovascular risk factors as early as possible in the stage of CKD, where other CKD-related risk factors have not crept in. Cardiac troponin is an extremely enigmatic thing, because the patients with suffering from chronic kidney disease, while present with a suspicion of acute myocardial infarction, you need to know that the troponin level is always raised in majority of patients of CKD. The mechanism is not known, though it is not universal. But it is also true that the serial measurement over a period of 4 hours to 6 hours, it shows that the troponin is rising, is the proper clinical setting of AMI, then the diagnosis can be made. Otherwise, it is also important to learn that sustained rise of cardiac troponin in a patient suffering from CKD has been associated with a higher incidences of cardiovascular disease. Heart failure is tremendously important. It is not only associated with the extracellular volume expansion and related hypertension, but also because of so many other issues associated with left ventricular hypertrophy and dilated cardiomyopathy, which is often seen in CKD patients. And thus, heart failure and sudden cardiac death are probably more important contributor of cardiac mortality in CKD individuals. Low pressure pulmonary edema will need to be learned, and sometimes it is unassociated with the extracellular volume expansion, unassociated with the increased volume load, but it has been found to have associated alveolar capillary permeability increment, and it is associated with the normal capillary wedge pressure in the pulmonary arteries or a mild elevation, and the X-ray may show battering appearance in the chest X-ray suggestive of low pressure pulmonary edema, But once you identify this thing, because of the increased alveolar pulmonary capillary permeability, in absence of extracellular volume expansion or hypertension of that magnitude to give rise to pulmonary edema, we may resort to dialysis treatment because that's become very rewarding in these cases. But one particular thing I want to mention is the low blood pressure carries actually worse prognosis than the high blood pressure. What is meant by that? That doesn't mean that you have to achieve low blood pressure, high blood pressure patients need to be treated more aggressively to achieve a low blood pressure. Actually, this is a thing of inflammation syndrome, malnutrition inflammation syndrome caused by the chronic inflammation may give rise to not only weight loss, but also hypolipidemia and hypotension, which together has been found to have a worse prognosis as compared to individuals with a normal body mass weight, body mass index, and high blood pressure and high lipid levels. So this is the feature of individuals who are on chronic maintenance hemodialysis for a prolonged period of time, and sometimes pointing to the caregiver about the worser prognosis as compared to other individuals, because that signifies a more severe chronic inflammatory state characterized by more severe nutritional deficiency, as well as there is left ventricular functional decrement in association with the low blood pressure. Pericarditis seen in advanced uremia in underdialyzed and non-adherent patients, and we need to understand that there is chest pain with respiratory excursion and in the precordium, and sometimes the chest pain may not be there. There could be pericardial effusion, and the ECG shows there is depression of the PR interval with a diffuse ST segment elevation, as we find in all pericarditis. But it is also important to identify some other cause of pericarditis, even in CKD patients, because that is not universally common. And particularly in today's modern setting, pericarditis is not that often seen. So far as the hematological thing is concerned, so far as the anemia, I have pointed out about the unique contribution of anemia, not only to the daily life activity, but also to neurological function, but also to the patient's ability to perform, the cardiovascular health, increased incidences of left ventricular hypertrophy and heart failure. And all these together is tremendously important so far as the patient's treatment is concerned. So addressing anemia and achieving a hemoglobin acceptable range of may 11 gram or 11.5 gram is to be achieved. And we all know that the transfusion which was needed earlier has been replaced by the erythrocyte stimulating agents. But more and more passage of time, we have understood that these erythrocyte stimulating agents in the form of EPO and other congeners have not been able to reduce the mortality, morbidity, as well as the cardiovascular events in patients with anemia. Rather, in some series of literature, we find that there is increased incidences of stroke when the patient was treated with erythropoietin, when the patient was suffering from type 2 diabetic nephropathy. And the erythropoietin, though given in those patients, has given rise to increased incidences of stroke, thromboembolism, sometimes extra aggravation of hypertension, and sometimes the erythrocyte stimulating agent resistance may be encountered, which need to be obviated by higher dosage. So all these things have given the researchers some unique understanding of iron homeostasis alteration in patients with chronic kidney disease. We know that hepcidin has been identified to be the most important hormone liberated from the liver, which has got immense role in iron homeostasis, not only in iron absorption, but also in circulation and utilization by the cells. So it is important that this hepcidin excess, which is there because of the chronic inflammation, And because of the reduced renal clearance, the combination of the two has got a raised level of hepcidin continuously in advanced CKD patients, particularly patients who are on maintenance hemodialysis. And in the earlier stages as well, this is the molecular mechanism which is now being researched over the last 10, 20 years. But it is also important to learn that the hepcidin reduces the ferroportion from the enterocytes of the duodenum, as well as the reticuloendothelial cell macrophage, which is extremely important for the iron recycling being stored from the senescent red blood cells, are all being unutilized in the presence of very high hepcidin. So the people are trying to manipulate the treatment of anemia in chronic kidney disease by some modality which reduces the hepcidin surge, as well as some modality which increases the ferroportin liberation and its action, which is being actively counteracted by hepcidin. So if they can be augmented and made a superpower inhibiting the hepcidin. So these are the different avenues which are now in active research to identify the particular improvement of anemia should improve the mortality morbidity ratio. Abnormal hemostasis is also common. There is diminution of active platelet factor 3, abnormal platelet aggregation and adhesiveness, impaired prothrombin consumption. But we need to understand that there is also a risk of thrombosis. So thrombosis bleeding, both are together risky, particularly in a patient with nephrotic range proteinuria, with the loss of albumin as associated loss of anticoagulants in a large degree, can also contribute to increased incidences of thrombosis in this individual. And the people who have got increased tendency to bleeding when combined with increased risk of thrombosis, we need to be very, very judicious and very actively monitoring the use of anticoagulants in pressing situations. In neurology, we need to understand the memory, concentration, sleep disturbance are common and early, but the seizures and coma afflicting the central nervous system disorder is extremely rare in present day setting, because this sort of advanced uremia is much, much uncommon. But the peripheral neuropathy is very common and sometimes very disabling. And there is restless leg syndrome as well. And the patient's sensory affliction is much more common than the motor. The lower limbs affliction is much more common than the upper limbs. And distal affliction is much more common in the proximal. Autonomic neuropathy giving rise to unacceptable postural hypotension, some sort of periodic palpitation is quite common in them. And in neuromuscular, hiccups, twitching, cramps can occur. Asterix and myoclonus may be found in advanced cases of CKD, which are much rare. Most of the above conditions resolve with dialysis, but sometimes some peripheral neuropathy may tend to persist. We need to understand that if your patient is suffering from diabetes and the patient's diabetes has given rise to this diabetes nephropathy, it is likely to be associated with some other microvascular complication in the form of retinopathy or neuropathy. So peripheral neuropathy finding in a patient with CKD is not sufficient to be attributed to CKD. We need to understand the difference of diabetic neuropathy and the CKD neuropathy. Sometimes both coexist, but peripheral neuropathy only due to CKD is very well resolved by dialysis treatment. Gastrointestinal and nutritional factors need to be considered. Breakdown of urea to ammonia to saliva in the saliva is the cause of dysgeusia. We need to understand gastritis, peptic ulcer disease, more common in CKD. Mucosal ulceration may take place at any place of the GI tract, and the patient might present before you with upper GI hemorrhage. Anorexia, nausea, vomiting are usually contributing to the malnutrition, which is often present in them because of uremia. But weight loss, metabolic acidosis, and chronic inflammation, these are the pointers towards protein energy malnutrition, which are found in majority of advanced stages of CKD. It is important that the patient should be counseled by a proper dietitian expert in the kidney disease management, and the diets associated with the different symptom improvement is extremely available. The urea, the nitrogen protein excretion in the urine may be measured. And it is also true that the patient's food diary, as well as assessment of the body status, particularly to identify the lean body mass versus the fluid weight in patients with ACF volume rise, is important to identify dual energy X-ray absorptiometry, which is widely used. And the lean body mass is to be targeted with proper maintenance of nutritional balance by a proper, judicious, balanced diet with effective protein consumption. But we need to understand that anorexia, nausea, vomiting are sometimes very troubling symptoms, and protein restriction sometimes become very salutary in improving those symptoms. So far as the endocrine and metabolic alteration is concerned, we need to know that renal degradation of plasma insulin is reduced, and thus the plasma insulin availability secreted endogenously become more, and thus patients with advanced CKD, in spite of having diabetes, in spite of having any treatment, might develop hypoglycemia of some severity. But when your patient is diabetes and being treated by exogenous insulin, with progression of CKD stages, it is always encountered to have a lowering requirement of exogenous insulin for desirable glycemic control. It is important that we have to avoid the hypoglycemic and the sulfonylureas are also to be stopped when the EGFR is less than 50, except a very low dose of glycoside may be given. But there are some studies with glimepiride low dose also. It is important that we have been now armed with a particular variety of oral anti-diabetic drug in the form of SGLT2 inhibitor class of drug, which by inhibiting the sodium glucose transporter cells in the proximal renal tubule, they produces glycosuria. And this glycosuria definitely diminishes the hyperglycemia in diabetes, but it also been found to improve the renal functional decline as well as maintenance of eGFR for pretty long period of time. It is also associated with the cardiovascular death reduction and cardiovascular event reduction and hospitalization for heart failure reduction. All these is available because of the improvement of the restoration of the tubuloglomerular feedback. And thus, this is an exciting class of drugs, particularly in early cases of CKD along with type 2 diabetes. But there are now being researches going on in non-diabetic renal disease, and we will be able to find out their usefulness in non-diabetic kidney disease as well. Sexual dysfunction, oligospermia in male is due to low testosterone. Menstrual abnormalities, infertility, miscarriage due to low estrogen. But there are also other different hormones that are become dysregulated in the presence of CKD. Reversal of the above with renal replacement therapy and particularly renal transplantation. And the dermatologic manifestations, we need to understand that pruritus may be sometimes very disabling and very tenacious complication. The patient might have a widespread pigmentation all over the body, and this is due to urochrome deposition in the skin. We need to understand that the coexistent other factors like hyperphosphatemia may be the cause of pruritus, and the other disorders which are common in the form of scabies, there could be pruritus. But in the uremic patient, you have to identify scabies or hyperphosphatemia to identify the treatable cause. Sometimes pruritus may not be treatable with that particular effectiveness. We know that moisturizing solutions, the histamine blockers, and all that, and the ultraviolet rays are also being given. One very fascinating is nephrogenic fibrosing dermopathy, which affects the upper limbs as well as the lower limbs. With the advent of MRI imaging, by the exposure of gadolinium as in contrast, it is found to be excessively occurring, and now there is a recommendation that up to stage 3 CKD you can use gadolinium with caution, but for stage 4 and 5 you need to avoid, because the gadolinium exposure is associated with such disabling dermopathy, which might end up with loss of the limb. So it is important, but at the same time, when a particular patient suffering from stage 4 or stage 5 CKD has sustained a brainstem stroke, and you need to identify the involvement by the MRI with gadolinium contrast. So it is important that you may resort to immediate hemodialysis after the exposure to obviate such disabling complication. So thank you very much. We know that renal replacement therapy in the mode of maintenance hemodialysis is supported, but there is a huge advancement in the transplant treatment of CKD individuals over the last 10-15 years of time. And Professor Rajendra Pandey is actively associated with the transplant program of our state. I sincerely thank the organizers. I sincerely thank my coordinator as well as the whole team of API, and particularly Professor Rajendra Pandey, our moderator. Thank you, sir.
Thank you, sir. Thank you, sir, for narrating elaborately whatever was possible in 70 minutes time. Suppose, do we have time for questions?
Yes.